Howdy. Hi, can you hear me and see me?
Yes. Hello. Good morning, Professor.
Good evening to you.
Good morning.
All right. So
yes, thank you, and good morning to you. We are waiting for the participant to join us.
Okay.
Before that, we are going to show some video about the Iran and some music till everybody come to. Okay.
No problem. I'm here, ready to go. Just let me know what's happening. I'm all set.
Thank you so much. Good evening to you. Good morning. Morning to you. Hello, please hold on. Yes, please hold on. Hello, how are you? Hello,
سلام نداری؟ من نمی‌دونم که هم با پرسیدید. Hello.
Yeah.
Okay, good. Okay.
Good morning and thanks for accepting our program. And for the second time, thank you so much. And once again, should tell you a happy new year and hope you will have a very wonderful life in this coming year without coronavirus. Today we have Professor Dr. Sayedan. He's the international committee of our association, and I ask him please to give you a few words on behalf of Iranian Society of Dentistry. Dr. Sayedan, please say a few words to Professor Malamed.
Okay, hello.
Dr. Sayedan,
Hello, everybody.
do you have my voice?
I have your voice. Do you have my voice?
Yes.
Do you have my voice?
Yes,
Okay,
I do.
good.
Yes, yes.
Good morning,
thank you.
Professor.
Carry on, please.
Good morning, Professor Malamed.
It
And
looks
good
like
evening, Dr. Nawab.
it looks like you're in San Francisco with the Golden Gate Bridge right behind you.
No.
The virtual.
that is so funny, you know. I don't know who put this background on me. I'm not in San Francisco, of course.
Of course.
You look like you're sitting in Tehran.
Yeah, exactly.
Okay. Anyway, it's a great honor for me and also a very great opportunity for all of my colleagues in Iran. And I would like to wish you a very good luck with this presentation on behalf of the Iranian Dental Association. Your name does not need any introduction. You are the star in the field of anesthesiology. Anybody who starts anything in dentistry with a simple injection knows Professor Stanley Malamed. As a New Yorker, I greet you to this program, and I'm sitting here with my pen, of course, in San Francisco to write down all the notes, and I will have lots of questions. Best of luck, Professor Malamed. It's a great honor for me.
Thank you very much. Thank you. Okay, so are we going to work now?
Thank you. Professor
I think you have to
Malamed,
share the screen.
Yep.
Yes, if you want to say anything you want for under a few minutes till other friends to join us, I think it might be better. Or if you want to start it, it depends on you.
Okay, well, it says, I'm trying to share the screen. It says the host has disabled participant screen sharing. So you have to allow me to
Yes,
screen share.
I make it, Yes, wait, give me a minute.
Okay, give you a minute. Okay.
Now you are able to share a screen.
I don't want to. No. Okay. Okay, so let's go to work here. Well, yeah, hang on. Let's go to work. Let's see what's going on here. Play. Okay, can you see my
Yes,
screen?
correct.
You got it, yes?
Sure.
Okay, great.
Yes,
Great.
we can.
Yes, of course.
Okay,
Yes.
so for those of you who are here, thank you for being here again and Happy New Year. This is part 2. So just a little refresher. I am Dr. Stanley Malamed. I am a dentist anesthesiologist based in Los Angeles, California, born and raised in New York. But I've been out here in California now since 1973 for a long time. And for 40 years, I taught at the University of Southern California School of Dentistry. I retired from my full-time teaching in 2013. And these are the 3 textbooks. These are my 3 textbooks that I am hoping that many people out there in the audience know very, very well. If you don't, I need you to buy them because of the pandemic, I haven't been earning any money, and the Malamed family is desperately in need of you to buy my books. So my email address, and after the presentation in December, I did get a number of emails from you. So if anybody has any questions for me, I will have a little time at the end of the program for questions. But if anybody has questions later, feel free to email me at that address. So back in December, we talked about the preparation of the dental office and staff for medical emergencies. And I discussed one specific type of emergency, which was seizures. We talked about the epileptic seizure and local anesthetic overdose. In today's program, I want to discuss 2 more things. We want to talk about bronchospasm, which is the asthmatic attack, and I want to talk about cardiovascular emergencies. So to go to work. We start out with discussing what the overall category is respiratory distress. And when I give my full day presentations, we talk about a conscious person whose chief complaint is they're having difficulty breathing. And the most common of these is the real name of this is asthma. The problem with asthma, if you look at the picture here, you can see this is a bronchus. We have the trachea, we have the bronchus. It's a cartilaginous tube surrounded by a layer of muscle. And what happens in the asthmatic attack, which is called bronchospasm, if you watch the picture carefully, what happens is the airway narrows down. The muscles go into spasm. And even though the airway is still open, the person who's having bronchospasm, having the acute asthmatic attack, is having extreme difficulty getting air in and out of their lungs. They can, but with much difficulty. So essentially, there are 2 different types of asthma, even though bronchospasm is the end result. So the treatment of whether it's allergic asthma, an allergic reaction, for example, to aspirin, very, very often is bronchospasm. And non-allergic asthma can be exercise-induced asthma, stress-induced asthma, which in our dental environment, of course, is something that we're going to see. The patient comes in who has a history of asthma. They're scared of going to the dentist, and people can faint when they're scared. But an asthmatic individual, when they're scared, is more likely to have an asthmatic attack. So basically, you want to find out what type of asthma they have. Half of all asthmatics, mainly children, have allergic asthma, and the other half of asthmatics, mainly the older persons, adults and on up, have non-allergic asthma. But the basic problem is the same in both situations. The problem is bronchospasm. The treatment is a bronchodilator. And throughout the world, the most commonly used drug, this is the drug that the patient will carry with them. They call this their rescue drug. When they have an asthmatic attack, it's a meter dose inhaler. In the United States, the chemical is called albuterol. Outside the United States, the same chemical is called salbutamol. It's an inhaler, and the patient will simply place it in their mouth, and as they inhale, they activate it, and the medication hopefully will get into their trachea and into their bronchi and open up their airway. You're going to see a video of this in just a moment. So again, this is the drug. This is I guess the American version of it here, albuterol, but most asthmatics have this medication with them all the time. It's a life-saving drug. Again, they call it the rescue drug. It keeps them alive by opening up their airway. So I'll be quiet in a moment, but what you're hearing is breathing. At the end of each of these breaths, you hear a whistling sound. Right there. Right there. Okay, now that is bronchospasm. When the airway is open, the way we are right now, breathing is very quiet. In fact, if you were attempting to listen to a patient breathe in a dental office with a handpiece on and suction on, you probably couldn't hear it. But when the airway narrows down and airflow becomes turbulent, it gets louder. The sound of breathing gets louder, and that wheezing sound is diagnostic of bronchospasm. So the patient who's having an asthmatic attack, they very often will cough, and I'm going to cough not on purpose, but I had a cough. Wheezing, the word dyspnea simply means difficulty breathing. The patient will normally spontaneously sit up. The patient who's having a hard time getting air in will assume a position that for them is most comfortable. And in virtually all situations, an asthmatic patient, perhaps lying in your dental chair, you're treating them, they're in a supine position or semi-supine position, will probably push the doctor's hand away and they'll sit up spontaneously. And the reason very simply is they can breathe better. They begin to use muscles for breathing that are not normally used. Most of our quiet breathing is done with the diaphragm and the intercostal muscles between your ribs. Most of it is done by the diaphragm. When a patient has difficulty breathing, they tend to use, again, these accessory muscles are their neck muscles, their back muscles, and their abdominal muscles to help force more air into their lungs and out of their lungs. A person who is having difficulty breathing, I would assume, is going to become more anxious. And the word tachypnea simply means a more rapid rate of breathing. So I'm going to show you a video of a rather severe asthmatic attack. And what happens, when you're breathing, what happens, a normal breath, okay? Your diaphragm contracts, your chest cavity expands, producing a vacuum inside your chest, and air is sucked in. Well, when the airway narrows down and the chest expands, the vacuum forms, but air can't come in because the airway's narrowed down. And what you see in this picture is the areas in dark blue where the soft tissue between the ribs, intercostal, right above the clavicle, supraclavicular, it is being sucked into the air, into the chest. And this is a sign, again, it's called soft tissue retraction. So this video comes from Australia, and with an Australian accent. I know my accent is probably pretty bad also, but the Australian accent. This is a young man, teenager, who is having a really severe asthmatic attack.
15-year-old Chris is having a severe asthma attack. His immune system has made what could be a fatal mistake and is shutting down his airways. Without help from the medical team, Chris's body may shut down completely. You're not going to die. You're not going to die. You'll be okay. The breathing tubes in Chris's chest are squeezing tightly shut and filling with sticky mucus, blocking his vital oxygen supply. If he's not treated soon, he will die.
It's a really life-threatening episode of asthma. Asthma is pretty common in our community, and most of the time it's not this life-threatening, but this one is quite serious.
Chris's allergic reaction has tricked his immune system into shutting down his airways, blocking vital oxygen to the rest of his body. The drugs are supposed to help the muscles around Chris's airways to relax, but there is a problem. The mucus stops the drugs from reaching his blood supply.
Through the veins to try and help it out. Because sometimes the lungs close down so much for this stuff to work.
Time is running out. Chris's body takes emergency action. His shoulders and neck muscles swing into action to help inflate his lungs. But even this is not working. As the pressure mounts, the team must find a treatment to get the drugs past the mucus. Chris is by no means an isolated case. 1 in 9 Australian children suffer from asthma, but for Chris, the situation is looking dangerous.
Chris is currently having Ventolin or salbutamol through a nebulizer, which he's breathing into his lungs. This acts on the muscles around the small airways and helps to open them up. Unfortunately, sometimes when the airways are very closed down, the salbutamol doesn't reach the areas that it needs to get to. The inhaled Ventolin is not working, then we often will go to a different form of medication. Again, a relaxant for the muscles around the small airways, and it helps to open those airways up. And it's given as a one-off dose over about 10-15 minutes in severe asthma.
Inside Chris's body, the airways start to open as the drugs take effect. Air finally returns to Chris's lungs, inflating the 300 million tiny air sacs.
Chris, can you get better?
At last, he can breathe.
Chris seems to be feeling a lot better now. The intravenous medication seems to have taken effect. He still is very tired because he's been working very hard with his breathing, but we're a lot happier with his clinical progress now.
All right, now that is a situation that is not likely to be seen in the dental office. That's sort of an extreme example of what an asthmatic attack can be like. So let's go back to this patient of ours. The patient comes in, they're lying in your dental chair in a supine or somewhat supine position. They have an asthmatic attack, and what I will venture to guess they're going to do is push your hand away and sit up. So the first thing, we went through this algorithm in the first session. This is the way we treat all medical emergencies. We position the patient, we assess circulation, we assess the airway, we assess breathing, and D will stand for definitive care. So as I said, positioning, the patient will do this by themselves. They will probably sit up because they're most comfortable. Now, the patient is conscious. They can still talk to you, although they're having difficulty breathing. So circulation, airway, and breathing are okay. They're not perfect. Airway and breathing are not perfect, but there's nothing that we need to do as far as that's concerned. So we're down now to definitive care. And definitive care, if the patient is an asthmatic and if they have their medication with them, allow them to treat it because they do this by themselves on a regular basis. The patient knows their asthma, okay? They have their medication and they'll administer the medication to themselves. And in virtually all of these situations, it'll work. It opens up the airway and the patient's fine. The patient usually uses 1 puff, maybe 2 puffs, but again, the patient knows their asthma. Once the asthmatic attack is over, there is no compelling reason to not continue with planned general treatment. In other words, you can. You can. Once it's over, they're fine. If you, the doctor, and the patient both are comfortable with continuing, then go ahead and do it. But what you need to do is find out why it happened in the first place. And as I said earlier, half of all asthmatics have non-allergic asthma. And in most situations, especially within a dental environment, it's stress-induced. Some people will faint, as I said earlier. Other people may hyperventilate, but asthmatics have asthmatic attacks. So what you want to ask them is, Stanley, the patient, what happened? And the patient will very often say to you, Doc, listen, I thought I could handle it, but in other words, whatever you were doing for them, they would say you're doing it to them, which has a more negative connotation. They were afraid of. Okay, they were afraid of it, and the macho guy sits there. Okay, and in that situation, this patient has an asthmatic attack. So find out why it happened and take whatever step or steps are necessary to prevent this from happening another time. So that's the typical asthmatic attack. Okay, 1 or 2 puffs of the bronchodilator, the patient is fine. By the way, you can also administer oxygen to the patient, even though I didn't mention it. Oxygen can always be administered during an asthmatic attack. So the question on the slide right now is, when should emergency medical services be activated during an acute episode of bronchospasm. And we talked last week, last December 22nd, about your 911. 911 is United States. In Iran, it's 115. You're going to call for emergency medical services when the asthmatic patient tells you. They know their asthma. They know that 1 or 2 puffs of my medication normally works. Doc, it's not working. Call an ambulance. Okay, the patient, this is so easy. The patient will tell you. Okay, so that's when you're going to make that phone call. Now, the other part of this is what is called status asthmaticus. Now, status asthmaticus, we talked last time about epileptic seizures that don't stop, status epilepticus. All right, well, status asthmaticus is bronchospasm that doesn't respond to the bronchodilator. Okay, and that is a life-threatening medical emergency. So in that situation, again, it'll be the patient who tells you, doctor, call the ambulance, call for an emergency ambulance, okay? And what you're gonna do while waiting for the ambulance to arrive is administer oxygen. You've already used the bronchodilator and it didn't work, and there's not much else that you can do. We'll discuss one option in a moment, but there's not much else that you can do. Hopefully the ambulance will be there within a short period of time. And by the way, when I get into the cardiac arrest part of this a little bit later, I have some statistics from one of the provinces in Iran with emergency ambulance responses. It's Hamadan province, okay? So activate emergency medical services. Now, this is what is happening to the patient during an asthmatic attack. Remember, the airway is not closed down. It's open but narrow. So they're not getting enough oxygen in. They're hypoxic. And hypoxia, you can see in the slide what it does. But the important part of what it does are the bottom 2 items. The heart cannot function properly if the heart muscle, the myocardium, is not getting enough oxygen. Increase in heart rate, irregular heartbeats, and if allowed to continue, this can lead to cardiac arrest. At the same time, the patient's not getting enough oxygen in, they're not getting rid of carbon dioxide. They are hypercarbic, too much carbon dioxide. And again, if you go down to the bottom of this slide, it can lead to cardiac arrest. Now, cardiac arrest in this situation is not going to occur rapidly. The patient, I mean, this sounds kind of bizarre, but the patient is slowly asphyxiating. So it's not going to be life and death within 5 or 10 minutes. It may be 30 minutes to an hour. So let's say this happens, the medication's not working. What can you do? The ambulance is on the way, okay, but it's not there yet. And the patient, the mucous membranes are cyanotic, they're profusely sweating, they're diaphoretic, their breathing is getting shallow. We talked about a basic emergency kit last week. I'm sorry, let me say last week again, okay, even though it was December. I mentioned that last year, the single most important drug in the emergency kit, in emergency medicine, is epinephrine, adrenaline. And whether you have it in, as you see here, an ampule or in a preloaded syringe, this epinephrine is the best bronchodilator there is, bar none. Well, why is it not used regularly? Why is albuterol used? Salbutamol, why is it used instead? Because salbutamol is a very good bronchodilator that has little to no effect on the cardiovascular system, where epinephrine is a great bronchodilator, but has a tremendous effect, as you understand, has a tremendous effect on the cardiovascular system. And yes, the patient used epinephrine for their inhaler, and they died. They didn't die from asthma. They died from the effect of the epinephrine on their diseased myocardium. So that's why this drug, epinephrine, is held in abeyance. It's held aside unless nothing else is working. Okay, now where do we give this medication? This is the package insert. We have a device, and I'm not sure if it's available all over the world. It's called the Epipen. And the Epipen is an auto-injector. This is the device that people with severe allergies will carry with them at all times. And this is what it says in the package insert from the Epipen. The Epipen, or the Epipen Junior, which is for the pediatric patient under 30 kilos, should only be injected into the middle of your outer thigh, the upper leg. Okay, and that is a muscle that is called the vastus lateralis. So you see right here where there are a number of reasons that it's used, but let's just talk about the anatomy first. If you look at the picture on the left-hand side, this is your thigh. Where the syringe is at about 2 o'clock on the picture, that is the vastus lateralis muscle. Now, there are 3 reasons why this area is used. Number one, the victim, the asthmatic, can inject themselves. Okay, so using the arm, the deltoid muscle up here, would be rather difficult to do yourself. So number one, you can do it yourself. Number two, if you look at the anatomy of this is the thigh. The area where the injection is being given, the vastus lateralis, there's nothing there but muscle. The interior of the thigh on the left-hand side of the slide, you have the femoral artery, the femoral vein. In the back of the thigh, you have the sciatic nerve. And you don't want to start poking needles into a patient in an area where you might save the patient's life, but you also might produce permanent damage to a nerve or whatever. And the third reason is this muscle is considerably more vascular than the usual site, the deltoid muscle. So it means it works faster. Okay, so this is where the injection is going to be administered if it needs to be done. So that really, again, is our discussion. Let me go back to that last slide over here again. So the injection is given in the thigh. The patient is given oxygen at that same time, and hopefully the ambulance will arrive shortly. But epinephrine will open up the airway, and most likely in all situations will save that patient's life. Okay, so then let's move on to the other discussion I want, and this is one really where I usually spend 2 to 3 hours discussing it because, well, cardiovascular problems. And the usual presenting symptom is chest pain. And if you notice, the word pain is in quotation marks because persons who we'll be discussing angina and a myocardial infarction. People who have angina or an MI rarely, when describing it, use the word pain. They talk about it feels like there's an elephant on my chest. It feels like there's a boulder on my chest, but they don't always use the word pain in describing it. So to make a very long presentation more compact, if you will, the heart is a pump. Very, very simple, okay? The heart is a pump. Let me go back to this. So let me go back to the heart being a pump here. Venous blood, and forgive me for being so basic here, but I like to go back and really go back over basics when I give these presentations. The right side of the heart receives venous blood from the venous circulation. It pumps that blood through the lungs where it's oxygenated, and it goes into the left side of the heart. And the left side of the heart pumps blood out to the entire body. Very, very simple, okay? Now, I'm showing you this is an electrocardiogram. This is what is called a normal sinus rhythm. I'm not going to go into rhythms to any great detail, but what I want you to notice here, though, is you see that spike, how narrow it is? Okay, this is when you see that spike, it is actually called a QRS complex. And that is when the ventricles are contracting. They're pumping out blood. This is what it's supposed to look like. A narrow spike. Okay. The blood flowing through the heart, the right side, the lungs, and the left side, is simply in transit. It's flowing through. The heart muscle, the myocardium, needs a blood supply. And the myocardium gets its blood supply from the coronary arteries. Now, the coronary arteries are the first branches that come off the aorta. So when the left ventricle contracts, blood is pumped out, blood goes into the left coronary artery, the right coronary artery, and these arteries you see in this picture are called epicardial. They are sitting on the surface of the heart. Now, in this picture, what they have done is they've dissolved away the muscle, leaving the blood supply. And you can see this is a massive blood supply. These are the arteries as they go into the muscle that actually keep the heart muscle functioning, supplying it with oxygen and other nutrients. So where is your blood right now? Well, 30% of your blood right now is in arteries. 65% of your blood is in veins, have given up a lot of its oxygen, heading back to the heart and lungs to be refilled. 5% of your blood is in capillaries. And the capillaries are actually the most important part of this entire system, because the capillaries are where cells breathe. Now, what does that mean? Oxygen leaves the capillaries and goes into the cells. The cells give up carbon dioxide, which is then carried away into venous blood. So this 5% of the blood that is actually found in capillaries is the most important part. Yes, I mean, arteries and veins are important, but capillaries are the most important part of that circulatory system. Let's have a look at cardiovascular disease. And I found some information about Iran, the top 10 causes of death in Iran in the year 2019. But when you look at the top 4, 3 of the 4 are cardiovascular. Ischemic heart disease, which, by the way, is the #1 cause of death worldwide. Stroke, cerebrovascular accident, and #4 is hypertensive heart disease. Okay, very, very similar to, I think this year perhaps we'll have to throw in COVID, but in 2019, it was ischemic heart disease, stroke, road injuries, and hypertensive heart disease. This is a survey. I showed part of this last time. It was done back in 1800. It was done back in 1993, I think. And I surveyed over 4,000 dentists. But on that survey, and this is the top 12 emergencies that they reported, 3 of them in blue, angina, cardiac arrest, and myocardial infarction were in that top 12. So I want to discuss these 3 items with you for the rest of this program. And again, those are the 3 we want to discuss. Angina was 8.3% of the medical emergencies, cardiac arrest 1.1, and myocardial infarction is a little bit under 1% of those reported emergencies. So let's go back. This is the coronary artery. This is one of those coronary arteries that are sitting on top of the heart, one of these epicardial arteries. And every time the heart contracts, blood flows through this, and as arteries get smaller and smaller, they will nourish the heart muscle. But this is what happens to our coronary arteries as we get older. Okay, so if you look again on the left-hand side is your healthy coronary artery. As you start going from left to right on the other diagram, as we get older, and if you look at the second diagram, second from the left, you can see there's a little bit of yellow stuff. That yellow stuff is plaque. And everybody has it. We eat, we live, we have plaque. And as we get older, the plaque inside the wall of the artery, not inside the artery itself, but inside the wall of the artery. And as that plaque accumulates, you go down to the third picture from the left, it begins to restrict blood flow. And this is, again, what happens to everybody. It happens in some people a lot earlier. Diabetics, for example. Coronary artery disease starts at an earlier age, progresses more rapidly. There's genetic problems. You can be prone to this through genetics. But this is a sagittal section of one of those coronary arteries. Okay, and what you see here, of course, is we have the red blood cells. And if this were animated, which it's not, the blood would be flowing from left to right. We have the muscular walls of the artery, and the yellow stuff is the plaque. Okay, so this is exactly what is happening to everybody. It occurs more commonly when arteries bifurcate, as you see here, where they divide from one artery into 2 arteries. So let's talk about the more common of these. It's called acute coronary syndrome, is actually the new terminology, ACS, acute coronary syndrome. And angina or angina is by far the most common. So again, in my survey, I talked about 8.3% of the doctors reported having had a patient, at least one or more patients, who had acute anginal episodes in their chair. So I used the term earlier, I said that pain is in quotation marks. So let me just read this to you, okay? Angina pectoris, commonly known as angina, is the sensation of chest pain, pressure, or squeezing, often due to ischemia of the heart muscle from obstruction or spasm of the coronary arteries. The process, again, of the arteries narrowing down over time. It is also known as angina of exertion. And the reason is a patient with angina, somebody in the audience perhaps has a history of it, and you're sitting there and everything is nice. But what happens is if the heart, whatever the reason, the heart has to work harder. The rate of the heart goes up, the force of contraction goes up, the muscle's working harder, it needs more oxygen. But because that coronary artery is narrowed down, it can't deliver any more oxygen. And now there's an imbalance between how much oxygen the heart muscle requires and how much oxygen it's getting. So again, anything that increases the workload of the heart can induce an anginal attack. And these are what are called the 4 E's of angina: exertion, emotion, eating, extremely cold or extremely hot weather. Well, the emotion one is the one that the dental profession has to look at. Again, simply, very similar to the asthmatic attack we talked about just a little while ago. Okay, a person with a history of angina, when they get scared, can faint. An asthmatic can faint. But when asthmatics get scared, they're more likely to have bronchospasm. When a patient with a history of angina gets scared, they're more likely to have an anginal episode. So how do we handle it? Well, very similar to the asthmatic patient. The asthmatic carries with them their rescue drug, their inhaler, their bronchodilator. The patient with a history of angina will carry around with them a bottle of nitroglycerin. All right, so let's go back to management. Okay, the first thing we do, since the patient is conscious, any position they want. And similar to the asthmatic patient a little while ago, most patients with angina are going to sit up. They feel more comfortable sitting up. If they want to lie down, it's okay also, but they want to sit up. We're going to assess the circulation. We're going to assess the airway. We're going to assess breathing. And there's nothing to do. They're conscious, okay? Circulation, airway, and breathing are okay. Definitive care in angina is nitroglycerin. And again, very similar to the asthmatic patient, the anginal patient carries with them their nitroglycerin. They will medicate themselves. We can also give them oxygen, okay? But nitroglycerin is the way it works. They take it to sublingual, it's a small little tablet placed under the patient's tongue. They usually use 1 or 2. And what nitroglycerin does is it dilates coronary arteries by about 28%. So you're increasing the blood flow through that artery. Increasing the blood flow increases the amount of oxygen that the myocardium is getting, and the attack is over. Okay, once the anginal attack is over, then exactly the same as the asthmatic patient, the dental treatment can continue. Okay, back to the asthmatic. In between asthmatic attacks, the asthmatic patient is normal. In between anginal episodes, the anginal patient is normal. But what you've got to do is find out why it happened. Why did this happen? And similar to what I mentioned a little while ago with the asthmatic patient, great, sorry about that. Similar to the asthmatic patient a little while ago, the patient's going to sit there and say to you, doctor, I thought I could handle it, but they were afraid of whatever you were doing for them, and they kept the fear internalized. And that's why this happened. So you need to take steps to prevent this from happening a second time. All right, so as I said, if both you, the doctor, and the patient are comfortable after the episode is over, then the planned dental treatment can continue at that following the asthma and the anginal attack. The only time, let me go back a couple of slides here. The only time that we, the dental doctor, should consider when a patient sits up in the chair and is having, in quotes, chest pain, the only time we should consider that that is angina as opposed to a myocardial infarction is when the patient has a pre-existing history of it. So what that means is this: a patient with no prior history of any cardiovascular problems sits up, perhaps puts their hand against their chest like that, and it's the first episode ever. There's no history of angina. Don't think it. Think myocardial infarction. And what I'm looking at here is you're getting into the system, getting into the 115 emergency medical services system as soon as possible. With angina, there's no need for it. In fact, as you'll see in a little bit, the anginal patient will tell you when it's not angina. They know it, just like the asthmatic will tell you when to call for an ambulance. The patient with angina will tell you, doc, this is not angina, call the ambulance, call 115. All right, so now what we're looking at is the acute myocardial infarction, which is the correct term. The incorrect term for this is the heart attack. And the reason that's an incorrect term is that this is going to progress, hopefully not in real life, but this will progress into a cardiac arrest. And the term heart attack is used for that also. And there's a tremendous difference between an acute myocardial infarction, the patient is alive, and a cardiac arrest, the patient is clinically dead. Okay, so we're going to use the correct terms here, an acute myocardial infarction. And what is happening with an acute myocardial infarction? Again, this was little under 1% of all the emergencies reported in that survey that I published back in 1993. What is happening is that narrowed down coronary artery that produced an anginal episode. Okay? There's still blood flowing through. Again, very similar to the asthmatic patient where the airway narrows down in bronchospasm, but is still open. What happens here is the artery closes down entirely. Okay, it is totally obstructed, the artery. And any muscle distal to it is going to die from a lack of oxygen. So right now in California, it is 10:07 in the morning, and I'm sitting here in a chair. And this is what happens. This is what is happening. Blood is flowing. And if you watch what's happening, the plaque, that yellow stuff, has just ruptured into the lumen of the artery. And those little white things are platelets. They get sticky, they form a blood clot. Okay, and that's what happens in a myocardial infarction. The muscle on the right-hand side of the slide, the dark area in this picture, is now not receiving any blood, no oxygen. And that heart muscle is beginning to die. Now, the reason I said it's 10:07 here in the morning is that this is a study that was done probably about 30 years ago. What was the victim doing? What was the patient doing when that rupture into the artery occurred? Take a look at that. 51% were doing nothing, sitting in front of their computer screen, doing nothing. 18% modest or usual exertion. 8% sleeping. Okay, yes, 13% physical exertion, but the point here is it happened at 10:07 in the morning. Whether I was at home, whether I was out running, eating a meal, sleeping, it happened at 10:07 in the morning. It was not related to what we were doing. If it happened in a dental chair, it was not related to what we were actually doing for that patient at that moment. So again, acute coronary syndrome, on the left-hand side, you see angina. You see the artery is narrowed down, but blood is still flowing through. With the acute myocardial infarction on the right-hand side, you have a blood clot, a thrombus, coronary thrombosis would be a good term for this, that totally obstructs that coronary artery. All right, 115, okay? 115. You're going to position the patient comfortably. But keep in mind that they are still conscious. We'll assess circulation, airway, and breathing, but there's nothing for us to do because they're conscious. And we'll talk about definitive care. Okay? The classical symptoms, and other than where it says on the right-hand side of the slide, crushing chest pain, nausea or vomiting, sweating, the skin becomes pale, mucous membranes may become cyanotic, they have difficulty breathing, and I would think normally, naturally, they would become very, very nervous, thinking this is it. This is the big one. I'm going to die. So again, we made that phone call. We made that phone call for 115. What can we do? All right, so here's our algorithm again. Hey, the patient is conscious, any position they want. Usually they're going to want to sit upright because they feel better. There's nothing for us to do in the way of circulation, airway, and breathing. When it comes down to definitive care, yes, we're going to activate emergency medical services, but you see the words, the letters MONA, the acronym MONA, M-O-N-A. Okay, now, in most, I'll go into that in a moment, but in most dental practices, 2 of the drugs we talked about back in December in our bare bones basic emergency kit were nitroglycerin and oxygen. So MONA is the acronym for the pre-hospital management of a suspected myocardial infarction. And this is what the acronym is. M stands for morphine, O stands for oxygen, N is nitroglycerin, A is aspirin. 3 of those 4 drugs are part of our bare bones basic emergency kit. Morphine is not. So what are we going to do? We made the phone call for 115. We'll administer oxygen. Okay, we'll administer aspirin. Nitroglycerin, if this man were an anginal patient and he's taken his nitroglycerin thinking his problem is angina, it didn't work. Okay, so oxygen and aspirin. And oxygen, again, on the left-hand side of the slide, you see we don't have this in the United States. It's a pre-mixed cylinder of 50% nitrous oxide with 50% oxygen. The brand name is Entonox. This is not available in the United States. But if this is available and you have this, nitrous oxide is a great substitute for morphine. It's as analgesic, it sedates a patient. It's a great thing to use during a suspected myocardial infarction. If you don't have it, oxygen should be delivered to that patient. Aspirin, preferably powdered. Yes, a regular aspirin tablet chewed and swallowed with water, but powdered aspirin works more rapidly. Now, what is it going to do? Aspirin is a thrombolytic agent. It's not going to dissolve the blood clot and make it go away. It won't do that. It prevents the clot from getting any bigger. Now, why is that important? Because if that person gets into the hospital's emergency department rapidly, they can have what is called a primary balloon angioplasty, also known, as you see on the bottom on the left, percutaneous coronary intervention, where a catheter can be threaded from the femoral artery in the groin into the obstructed coronary artery, and a stent, a metal framework, the 3 pictures of the arteries on the bottom of the picture on the right-hand side, a metal stent can be placed in there to reopen the artery. Aspirin prevents the blood clot from getting too big. If it's too big, they can't do this. So powdered aspirin or regular aspirin chewed and swallowed with a glass of water. Obviously, a contraindication for that is the presence of an allergy to aspirin. So the ambulance will arrive on the scene, and quite honestly, you've done your job. What they're going to do is hook up the electrocardiogram, perhaps give medications to the patient, and they'll transport that patient to the hospital's emergency department, their casualty department. So what's going on? What is going on in that person's heart while they're having a myocardial infarction? And if you look on the left-hand side, the blood clot occurs. And that muscle, that dark brown area, is not getting any oxygen. The muscle is in the process of dying. It is not dead, it is dying. And when cells are dying, they're not getting enough oxygen, they become hyperexcitable. And when myocardium becomes hyperexcitable, the rhythm of the heart becomes irregular. And the correct term for this is dysrhythmias, abnormal rhythm. So we go back to that slide I showed you a couple of minutes back. This is what a normal heartbeat looks like, the narrow spike. This is normal heart. I want you to take a look. 90% of the work of your heart is done by the left ventricle. Take a look at the thickness of the left ventricular muscle compared to the right ventricle. Sadly, most myocardial infarcts affect the left ventricle, the part of the heart that we need the most, that we can least afford to be damaged, is the part of the heart that is most often damaged. All right, so this is what is happening in that patient. And if you notice, I have it circled in blue, those beats that you're looking at there do not look like the ones right next to it, the narrow spike. They're larger, they're longer. And these are called premature ventricular contractions. And if you notice that all three of these are the same, they're called monomorphic, which means they are all occurring in one spot in the damaged myocardium. Worse than that, if you look at the three on this slide, is polymorphic. They all are different. And that indicates that a larger area of that patient's heart muscle is ischemic, is not getting enough oxygen. Okay, so why is that important? So every time your heart contracts, the left ventricle that pumps blood out to every cell in the body will pump out between 55 and 70% of the blood that is in it at the end of diastole. Diastole is when the heart refills with blood. So the LVEF ranges, they normally talk about the numbers 0.55 to 0.7, which is again 55 to 70% of the blood is pumped out. So what is the problem? Well, when the heart contracts prematurely, it hasn't filled properly. And if it contracts with less blood inside the left ventricle, little to no blood is being pumped out. So without going into a long discussion on this slide, we start on the left-hand side. The green arrows are normal heartbeats where the blood is being pumped out properly. The red arrows are the premature contractions. And take a look at on the left-hand side of the slide, the space between the two first green arrows. So the green arrow, the heart contracts, pumps out blood. The space between the two is diastole when the heart refills. The second green arrow on the left is when the heart contracts and pumps out blood. The space between the green and the red is when the heart begins to refill. But before the heart is totally refilled, the heart contracts again, premature contraction. And little to no blood is being pumped out. So what on this slide, there are 11 contractions, 8 of which are normal. This patient is pumping out between about 73% of his or her normal cardiac output. This patient is conscious, but they're not pumping out enough blood, not enough oxygen. So the patient's mucous membranes are cyanotic, the skin's an ashen gray color, they're sweating profusely, and they feel tired. This is what is happening to this patient during a myocardial infarction. Now look what's going to happen. More frequent. Every other heartbeat now is a PVC. And this person's cardiac output is now down to 50%. Still conscious, but more symptomatic. So to go back to last month's discussion, in the United States, our legal obligation to this victim of any medical emergency is for us to try to keep that person alive until they recover or until another more qualified individual takes over responsibility for their treatment. So the question is, what exactly have we done? And the answer is nothing. We've done Mona, we've done morphine, probably not, oxygen, nitroglycerin, and aspirin. Okay, and essentially nothing, because the blood clot is still there. The myocardium is ischemic. The victim is still symptomatic. Their heartbeats are becoming more irregular. but they're still conscious. So the pump, even though it's damaged, is still pumping. And quite honestly, if the emergency ambulance arrives on the scene and that patient is still alive, we've been lucky. We have been lucky. And that's why getting into that system, 115, is so important. In the United States, going back to 2015, the most recent statistics I could find, 70% of out-of-hospital cardiac arrest occurred in the victim's home. Another 20% occur in public settings. So that's 90% of cardiac arrests occur outside of the hospital environment. So myocardial infarction, conscious, becoming cardiac arrest. Now where it says on the left-hand side, most OOH, out of hospital cardiac arrests, are related to the onset of, and you'll see this in a moment, ventricular fibrillation. And most often, this will occur within the first hour after the onset of the obstruction, after the onset of symptoms. So again, getting in the system, 115, is the most important thing that we can do, whether it's in a dental environment or at home, if you have a what is called a suspected myocardial infarction. Take a look at this number. This is why the mortality rate is so high. In the United States, from the onset of symptoms until that person finally makes that phone call for 911, they wait almost 5 hours. And that's why they die at home. Because nobody believes it'll ever happen to me. It'll happen to, yeah, everybody else, but not me. I'm immune. And that's why they wait so long. That's why they die at home. So let's then finish up with our discussion here and talk about cardiac arrest, okay? Cardiac arrest. Happily, this was not one of the more common medical emergencies in my survey. And in cardiac arrest, the heart is still beating. It is simply no longer pumping. And that really is an important concept. The heart is a pump. And if it stops pumping blood, well, the patient dies or is dead anyway, okay? Now, let's talk about some rhythms. I'm going to go through this kind of rapidly because of the time factor right now. But there are 4 rhythms that occur in cardiac arrest. And I'm going to go through, I'll show you these in just a moment, but we have what is called pulseless ventricular tachycardia. Everybody knows about ventricular fibrillation, asystole, and something called pulseless electrical activity. So in a normal situation, the very first of these rhythms that occurs is ventricular tachycardia, and you can see it up here. And what we're looking at here is every one of those heartbeats is a PVC. The damaged area of, I showed you a strip of 11 heartbeats where 3 of them were PVCs. I showed you by Gemini where every other heartbeat was a PVC. Every beat here is a PVC. And with PVCs, there's little to no cardiac output. So this person, again, is unconscious, is not breathing, and has no pulse. So ventricular tachycardia on the left-hand side of the slide will degenerate after several minutes, perhaps 4, 5, 6 minutes, into what you see in the right-hand side of the slide, which is called ventricular fibrillation. And ventricular fibrillation, and you'll see this in a video in a couple of minutes, is simply an unorganized quivering of the myocardium. Okay, so this initially, there's a lot of activity here, and we call this, you see the adjective coarse ventricular fibrillation. As that muscle fibrillates, using up whatever oxygen the muscle still has, it gets weaker, and we have what is then called fine ventricular fibrillation. Ventricular tachycardia and ventricular fibrillation are known as shockable rhythms. We'll end up our discussion in a couple of minutes with a look at defibrillation. Asystole on the left and pulseless electrical activity on the right are simply called non-shockable rhythms. This is ventricular fibrillation. Now, this is ventricular fibrillation 30 times faster than real time. So this, what you're seeing here is 5 minutes, 300 seconds of ventricular fibrillation in a 10-second video. Okay, you can see how the muscle is simply quivering. There's no blood being pumped out in this situation because there's no contractile force. Asystole, flat line, it's usually called a flat line. A, none, systole contraction. This is not a shockable rhythm. Once muscle is dead, you can't bring it back to life. So let's go through this. This is the usual progression that occurs in cardiac arrest. And we have an occasional PVC there, and the PVCs become more frequent. This patient is still conscious. They're symptomatic. They're having a myocardial infarction. Now the patient, this is ventricular tachycardia. The patient has become unconscious, no breathing, no pulse. After a period of time, perhaps a minute or two or three, without any resuscitation being done, this becomes coarse ventricular fibrillation. As the muscle quivers and uses up its available oxygen, it becomes weaker and weaker. And perhaps right about now, we could call this fine ventricular fibrillation. And after about 6 minutes of no resuscitative efforts, the patient will go into asystole. So that is the usual progression that occurs in a cardiac arrest when no resuscitative efforts are done. So when the heart stops pumping blood, this is what happens. There's no palpable pulse. The patient loses consciousness and they stop breathing. And if you look at the bottom of the slide, what do we call that? They're dead, but they're clinically dead. They look like they're dead. Are they biologically dead? Not yet. They look like they're dead. Now, biological death is when the cells in the body use up every last molecule of oxygen. Keep in mind the capillaries, okay? When the blood stops circulating, there's still oxygen inside that blood, inside the capillaries. And when that oxygen is used up, then the cells die. And cellular death, biological death, is irreversible. Okay, in the absence of doing anything, that patient is going to die. Doing something, CPR, defibrillation, there's no guarantee it's going to work, but we are giving the victim a chance at survival. Okay, and that's the important thing. That is why CPR and defibrillation are so important. We're trying to prevent the permanent death of that victim. All right, so we have clinical death at the onset of cardiac arrest. We have biological death that occurs somewhat later. And that's why resuscitation can work, because they don't occur at the same time. All right, now, why does CPR work? There's your heart. All right, your heart is, let's say it's a hollow bag filled with blood, located between two pieces of bone. Okay, and when we do CPR, and you can see that heart is in ventricular fibrillation, when we squeeze the heart between these two pieces of bone, we're forcing blood out. Okay, and that is exactly what we're doing when we do cardiopulmonary resuscitation. All right, so what normally happens in cardiac arrest? Well, for about an hour before the sudden cardiac arrest, the patient has symptoms. They may be dizzy, they're nauseous, they're short of breath, they have chest pain. But as I showed you earlier, most people don't equate that to calling an ambulance. They don't. So what happens now at time zero? At time zero, their heart goes into ventricular tachycardia or ventricular fibrillation. Circulation of blood stops. There's enough blood in your brain with oxygen that you will actually remain conscious for about 10 seconds once cardiac arrest occurs. But then that victim will lose consciousness. Okay. Brain cells, neurons in the brain, deprived of oxygen for as little as 4 to 6 minutes, will die. So if a resuscitation doesn't occur within the first 4 to 6 minutes, that patient may survive a cardiac arrest, but they will survive that cardiac arrest with permanent neurological damage. And if nothing is done between 10 and 14 minutes, that's when cells all over the body will die. Biological death occurs, and resuscitation is essentially, it ain't gonna happen. So how critical is response time to surviving cardiac arrest? And the biggest problems we have on the left-hand side is traffic. And I know you have in Tehran, you have traffic. We have traffic in Los Angeles. The ambulance, that ambulance in that picture is not going to get to that victim in a hurry. On the right-hand side of the slide is something even more critical. The fact that bystanders won't start CPR. That combination right there is deadly for that victim. When we talk about survival from cardiac arrest, we normally talk about survival to being discharged from the hospital. And you can see here on the left-hand side of the slide, those are the airport abbreviations for cities in the United States. And on the very top is Detroit, DTW. The survival rate from an out-of-hospital cardiac arrest in Detroit is 1%. Los Angeles, where I live, is 7%. Now go to the bottom of the slide, and Seattle, Washington is 62%. And those numbers basically deal with the response time of the ambulance and the fact that citizens will start doing CPR in some areas. And again, survival rates on the left-hand side of the slide, when no CPR is being done, after about 10 minutes, there is little to no chance of survival. On the right-hand side of the slide, when a bystander initiates CPR, you can see that at about 10 minutes, there's still a very good chance of that person surviving. This is an article I found from 2019. The out-of-hospital cardiac arrest in Iran. And as I mentioned before, it's from Hamadan province. 78% of the cardiac arrests occurred at home, very similar to the numbers I showed you in my slide from the United States. Between 8 o'clock p.m. and 8 o'clock a.m., that's when 65% of the emergency of the cardiac arrests occur. 26% were, I'm sorry? 26% were witnessed, 5% a bystander, perhaps a family member, began doing CPR. The mean response time for the ambulance was 6 minutes, and CPR was conducted for approximately 20 minutes in each of these situations. 76% of these victims had a non-shockable rhythm. They had either ventricular, they had asystole, was the most likely rhythm. ROSC, return of spontaneous circulation, means they were able to restart that person's heart before they got to the hospital, 8.3%. Survival to hospital discharge was 4.1%. This is the only article I was able to find recently from Iran and statistics about out-of-hospital cardiac arrest. So let's then go a little bit further than surviving to leave the hospital. Let's think about 30-day survival. Okay, have a cardiac arrest, be resuscitated, leave the hospital, and be alive 30 days later. This is an article from 2019, the New England Journal of Medicine. And in all patients with cardiac arrest, 7.1% survived. When the emergency responders did the defibrillation, 28% survived for 30 days or longer. When lay bystanders, this would be a dentist in a practice with an AED, 53% survived. Okay, so significant differences right there. So let's then finish up with a look at automated external defibrillators. And quite honestly, I've been discussing these things, been pushing them, hopefully getting dentists to have this not only in their dental office, but additionally at home. You saw the numbers where in Hamadan province, 78% of the emergency of the cardiac arrest occurred in the home of the victim. The same numbers were true here in the United States. What this machine does, it's a small computer that is programmed to recognize ventricular fibrillation and ventricular tachycardia. And if the victim has one of those rhythms, the machine is going to say to you, shock advised. If you place the AED on a person who's unconscious, no pulse, and they have any rhythm that is not ventricular fibrillation or ventricular tachycardia, honestly, the machine doesn't know what it is. It knows what it's not. It is not VFib or VTach. In other words, if I placed it on me right now and I have a normal sinus rhythm, the machine would say no shock advised. If I placed it on a person who was dead, I mean, been dead for days, they're in asystole, the machine would say no shock advised. The accuracy of these machines is really phenomenal. And that's why, look, I'm 99% in this study. Of 709 cardiac arrest rhythms, it accurately diagnosed 702, 99% accuracy. And that's why in the United States, AEDs are over the counter. You've maybe heard of Walmart or Costco. These are these big stores that sell everything. You can go in, anybody can go into one of these stores and buy an AED. How does it work? All right, so on the bottom, you see coarse ventricular fibrillation, which again is that uncoordinated quivering of the myocardium. The electrodes, there are diagrams on the electrodes, are placed on the right-hand side of the chest, on the lower left-hand side of the chest. The heart's located in the middle of your chest. And what you're doing when you press the button to defibrillate, you're sending an electric shock through the myocardium. What you're doing is you're depolarizing every heart muscle fiber simultaneously. This is what you're doing. So on the left-hand side here on the bottom, we have ventricular fibrillation. On the right-hand side, when we shock every heart muscle, we are actually turning off the heart. We are producing asystole. And look what happens. We produce asystole, hopefully, as the heart reprograms itself, reboots itself is a good way to look at this, okay? It comes back in normal sinus rhythm. The more alive the heart muscle is when you shock it, the better the chance of it coming back as a normal sinus rhythm. Now this video, this is the anesthesiologist's view of ventricular fibrillation. This is real life. This is real time. This is ventricular fibrillation in real time on a rather not healthy heart. That click you heard, I'll show you this video again, but that click you heard was the shock, and this is a normal contraction of that patient's heart. So let me show it to you one more time, okay? Anesthesiologist, this is during open heart surgery. Ventricular fibrillation is occurring. And this again is what it looks like. You'll see this on a rather unhealthy heart. In come the electrodes, you'll see on the left and right, a click, that's the shock. And the heart is now contracting in a normal sinus rhythm. That's what it's all about. Dental, back to the dental office, okay? Can chest compressions be performed in a dental chair with the patient in the chair? And the answer is absolutely, positively yes. This article goes back now to 2003. Anthony LaPere, a dentist anesthesiologist originally from Australia, did a couple of studies, and the answer is yes. The dental chair today, place the chair into a supine position, and you can effectively compress the adult victim's chest in the dental chair. So can we improve upon this, okay? Well, not really can we improve. Yeah, and the answer is yes, we can. And I because of the time factor, I took out some slides here on the what is called the ambulance drone. Drones now are everywhere. And it started in the Netherlands. It went then to Sweden. And now we're beginning to get this in the United States. A drone carrying an AED. And what it very simply, I think on the slides that I sent out, and I think you have a chance to download the PDF, but it cut the response time by more than 16 minutes in cardiac arrest. And if an ambulance drone can get there within 5 or 6 minutes versus 10 or 15 minutes, survival from cardiac arrest is going to increase dramatically. All right, so let me conclude then. And again, I want to apologize because I've had to, because of the time factor, condense everything. But in conclusion, okay, going back to the last month and now, the very first step in the management of all medical emergencies without any exception is basic life support as needed. So let's go to the left-hand side of this slide. In any emergency other than cardiac arrest, which is virtually all medical emergencies, we will properly position the victim. If they're unconscious, supine, feet elevated slightly. If they're unconscious, supine, feet elevated slightly. If they are conscious, any position they want. We will assess circulation, airway, and breathing and administer as needed. And then D stands for definitive care. On the right-hand side of the slide, in the unlikely situation that it is a cardiac arrest, positioning supine, circulation, we have to do chest compression, we have to maintain an airway, we have to ventilate the victim, and D stands for defibrillation. And again, I don't know the availability in Iran of defibrillators or AEDs, but when and if they are available, I strongly recommend, not only do you have an automated external defibrillator in your dental office, but because of those numbers I showed you where about 80% of out-of-hospital cardiac arrests occur in the home of the victim, I strongly recommend having one at home also. And if you go traveling, you're going out with your family in a car, you're going to go on a trip, whatever, put it in the boot. Just have it with you. It's not being paranoid, it's just being logical. Those devices save lives. So again, this is the algorithm, and our obligation to the victim is to try to keep that person alive, and those 5 letters are what will do it in virtually all situations. So that's it. It was a short and sweet presentation. I didn't cover everything I'd like to, but we discussed the seizures last time. We discussed the asthmatic patient, and we discussed cardiac problems with today's presentation. So I want to thank you. And I'm not sure, do we have time for questions? If there are questions, I'd be glad to answer them. Thank you. Hello?
Yes, thank you, Professor, for your excellent presentation. It's really everything you covered. It was so nice and very well done. Thank you so much. I have a few questions, and if any other people also having questions, please write it in the chat box on the bottom. You can write it. We will ask Professor to answer. Dear Professor, do you have my voice?
Yes, with a little echoing, but I have your voice, yes.
Dear Professor, do you have my voice?
Yes, yes. Can you hear me?
Do you have my voice, dear Professor Malamed?
We have your voice, Dr. Naval. We have your voice with a little of echo.
Yes, I can hear you. One of the questions is regarding the
I can't hear you. Repeat the question because I can't hear you.
Yes, I am getting him. I got his voice. My question is regarding the medical legal aspect of cardiac arrest or MI in United States. Is it? Yes, my question is regarding the medical legal aspect. Is it the dentist must recognize and diagnose different type of arrhythmia and treat as it, or it is not necessary and they should only, if there is a clinical death, do the CPR? And what is the percentage? Another question is the percentage of survivor only CPR and with defibrillator.
Okay, well, the first part of the question deals with rhythm recognition. The answer is no. most dentists are not trained. Most dentists don't have an electrocardiogram in their office. So when a person goes into cardiac arrest, they will be doing basic life support. Okay, circulation, airway, breathing, and circulation. We're going to call 911. You're going to call 115. More and more dentists, approximately half of all the dentists in the United States, report that they have an AED in the office. So when you start doing your CPR, your dental assistant perhaps gets the AED, you apply the electrodes, and from that moment on, the machine does the work for you. The machine will analyze the rhythm. You don't have to analyze the rhythm. The machine does it. And if the machine says to you, shock advised, then you press the button. And if the machine says no shock advised, by the way, the machine will then talk you through what to do. If it says shock advised, which means you're in ventricular fibrillation, perhaps, it'll say charging, machine is getting ready. It'll then say charged. It'll then say, do not touch the patient. It'll then say, press the button. If the machine, if the patient does not have a shockable rhythm, the machine will say, no shock advised, continue CPR. And again, as I mentioned before, the accuracy of these machines is 99%. So in essence, you don't have to be able to read an electrocardiogram. The machine is doing that work for you. Okay? I showed you survival rates. I showed you the survival rates. If somebody starts doing CPR and that same person can shock the patient, I think that slide talked about 30-day survival of around, I think it was over 50%. Okay, and overall it was 7.1% when no CPR was done and defibrillation was not done until the paramedics arrived. So having an AED, being trained in CPR, as all dentists are here in the United States, but not all dentists have AEDs. But that combination of AED and CPR, your survival rate is going to go up dramatically. Okay?
Yep. I guess Dr. Nawab is disconnected for the moment.
Okay. Are there any more questions then?
Let me check with you on WhatsApp.
Hello, Dr. Saeedan.
Hello.
Can you hear me?
Yes, I can hear you, Dr. Mortazavi.
Yes. Oh, Dr. Malamed, I am close to you in Los Angeles, in Valley area.
Where are you?
And right now, I'm in the United States, in Los
where?
Angeles.
Where exactly?
Valley.
I'm in the valley. Where?
In Valley Circle. I live here.
Wait, we live close to each other. I'm on Platte and Victory.
Okay, very good. I would like to say thank you so much for your excellent presentation, and probably, I'm MD and DMD, and I really pleased to meet you because I'm not far from here, and even without the internet, I can call you, by my voice.
Yep.
Because as I understand, you are not far from me, and I will be happy after Corona. I come to you and meet you any place is more convenient for you. And I appreciate. I trained at the University of Alabama in Birmingham, probably the same time you were as a resident,
Mm-hmm.
and because I completed my education, that was 1980.
Okay.
And one of my friends also was at the University of USC, Dr. Namazi Khai.
Oh, of course, I know him very, very well.
Right.
Yes.
So just I try to get rid of the Corona very soon, and I will call you.
Yeah. Oh, now, okay. Give me more precise where you're located. You said Valley Circle, but where?
West Hills.
Yeah, I'm in West Hills. But
Oh, really?
are you near the baseball fields?
Oh,
El Camino High School? Where are you located exactly?
uh,
I know the
that
rest
is
you don't
the,
care, but
I'm at the corner of Dory and Puzzle.
we live probably less than a mile away from each other.
Right, right. And you know, I bought your book years ago at the Congress we had in Las Vegas because I was as a professor of the and head of the Department of Oral and Maxillofacial Surgery at the University of Shahid Beheshti in Tehran. So I used a lot of the, you know, a lot of the material for my residence over there. But right now I am retired like you, and I live in United States close to you.
Well, it's good to meet you. So are there any questions that people have? Does anybody have
Yes,
any?
Dr. Sedan does have question.
I guess I could answer any questions on the chat. Maybe Dr. Navab can see anything on the chat, but here on my screen, I don't see any questions.
Okay. Well, it's time for you to have dinner. It's time for me to get out and do my morning run.
Good. Thank you very much, Professor Malamed. It was really informative, and I learned a lot. And I hope that I will go and buy an AED very soon. It looks very helpful.
It is very helpful. Thank you.
Thank you so much. Take care. Hope to see you very soon.
Thank you. Bye-bye.
Have a good day.
Bye-bye.
Bye.
Okay.
Dear Professor, once again, thank you so much.
Oh,
دکتر مرتضی سلام. دیگه الان
سلام.
دیگه خودمونی شد.
بله.
okay.
خودمونی که
خیلی ممنون که تشریف آوردید.
I'm signing off. Bye-bye, everybody.
Professor, thank you. Dr. Malamed, thank you.
Okay. Bye-bye.
Dr. Sedan, are you over there, right?
Thank you to be.
No, I'm talking to Dr. Sedan. Cover.
Us.
Are you still on? مثل اینکه ملت همه رفتن دکتر نوازم.
Thank you so much. I will.
Okay. صدات
طولانی شد دکتر، خیلی طولانی شد. شما کی تشریف آوردید؟
کجا؟ من 5 ماه اینجام، 6 ماه اینجام. دکتر نواب. نواب. Hello. Hello. الو دکتر نبا بازم صدای منو دارید؟ الو الو الو